This is the lecture on mood regulation. We're going to look at mood regulation more broadly, and then in the subsequent lectures we can apply this to the specific mood disorders. And I want you to start to understanding mood regulation as a dimensional concept that is applicable to major depressive disorder, bipolar, borderline personality disorder, disruptive mood dysregulation disorder, the whole range of disorders where there are abnormal mood states. So first, let's define emotion. It's actually a difficult word to define. Here are some of the dictionary definitions. They're not really that helpful. An instinctive or intuitive feeling is distinguished from reasoning or knowledge. As you can see under the right, it's a fairly modern word. Sort of in the 60s it really took off. And its origin, interestingly, not surprisingly, is from a Latin word to mean move. In the French, it has a term meaning excitement. So obviously we are above a baseline state when we are emotional. And interestingly, as humans, we tend to use, at least in English, the word feelings to refer to our emotions, which of course itself has a relationship to physical stimuli. So I feel the top of the desk, and I also feel bad or feel depressed. I think this is relevant in terms of understanding how the brain processes emotion. And here's a more specific scientific definition. Emotions are psychological states brought on by neurophysiologic changes. So they're not only the brain, but our periphery is changing. And they're associated with thoughts, feelings, behavioral responses, and a degree of pleasure or displeasure. So this word gets obviously intertwined with mood, temperament, personality. Now, the affect is an emotion or mood experienced at a given point in time. I'm going to come back to that in a moment. And an affective state at any given time is described by these three variables here. Valence is simply whether it's positive or negative, plus minus. Arousal is how energized you are. So arousal can be positive. You could be very happy, or it can be you're very angry or you're very sad. But that's usually measured via the activation of the sympathetic nervous system. All right. And then finally, motivational intensity. Usually an emotion puts us in a state where we're going to act. We're either going to move toward or away from the stimulus. And if we do interact with the stimulus, we're going to take some action toward that stimulus. Now, in your mental status examination, you use the terms mood and affect. There may be some debate here on how we define these things, but for the purposes of this lecture, this is how we're going to define it, and actually is the scientific definition as well. So an affect is any given point on that line at the second, literally the second of assessment. So we see here that this individual is having a changing affect. Let's say up is elation and down is depression for the sake of argument. And we see that the time period begins with them feeling elated, then depressed, then elated, and then depressed again. The intensity of the affect is governed by how far up or down the y-axis there are. And in our mental status exam, we should refer to that as the range of affect. And then the mood is described by the average or the summation affect over the entire period of the assessment. So we would say here, this person looks like they were 50% elated and 50% depressed. So we would say the mood during the mental status was both elevated and depressed. And the range of affect was labile because they're going back and forth over the course of the exam. Now, typically we use this shorthand and we just say the affect is labile, but really the affect is the second in time of the mood, and so in the mental status exam we're referring to the range of affect. This leads to confusion among the medical students because they'll say the affect is depressed. Well, that would be true if you're referring to a particular instantaneous second. Is the patient sad or depressed at that moment? But really, the mental status, we're describing the mood over a period of time. Now, sometimes the people say, well, no, Dr. Pliska, the affect is how I assess the mood, and the mood is what the patient tells me. Well, I won't get into that argument right now, but that's incorrect, at least for the purpose of this seminar, and we can debate more about it sometime over a beer. So coming back to the arousal concept, you might imagine emotion as being governed by two levers. One lever is the valence lever, the horizontal one, which can be either positive or negative. And then the vertical lever is the activation one. In the high state, the sympathetic nervous system is increased and parasympathetic system is decreased, whereas in the low, the sympathetic's decreased and the parasympathetic is increased. So the state of elation is high arousal and positive affect. The state of being chill would be positive affect and low arousal. And negative affect and low arousal would be lethargy, melancholy, psychomotor retardation, being bored. Now, unfortunately, we get into some trouble with this model in the upper left-hand corner, because here we have to squeeze anger, agitated depression, and anxiety. And probably, does aggression go here? Well, is aggression negative or positive? Well, defensive aggression is generally negative feeling if you're being attacked by somebody and you have to defend yourself. On the other hand, if you're watching The Equalizer and watching Denzel Washington beat up the bad guy, aggression may be positive, and you feel good and aroused about that. So this two-lever model is not the best in the world, but it gives us a way to think about emotion more generally. Now, human beings, we are capable of a wide range of different emotions, which are exhibited by a relatively new invention, the cell phone emoji. And growing out of that is the facial nerve, is responsible for the muscles of facial expression, and we can make all of these different faces, which presumably correspond to our internal state of feeling. And as of course you know, unless you're an actor, it's very difficult to have a face that is different from your internal state. And if you try it, like a forced laugh, people kind of know right away that something's not up. So how does the brain do all this? And here's something more confusing. I ask you to take a moment. What is this man's affect at this particular second? Well, he's got a furrowed brow. He's showing his teeth. He's obviously he's screaming. He's aroused. We know that. Well, of course, this is an Indian weightlifter who's just won the gold medal. So this is he is excited. He is feeling good. It's a moment of triumph for him. So, in general, the majority of people do guess that, but they can't exactly say why they do. But when we put it in the larger context, our brains then have no trouble telling us what's going on. Now here's a little different situation. This gesture to throw both hands either on top of your head, or in the case of the man with the watch in the middle, to cover your face. What has happened on the left? Well, this is a famous English football player, as they say, soccer as we say in this country, and he has just missed an easy goal. And his fellow fans are just very upset. And if you've been at a UT or A&M game when there's been some, or at the UT Ohio State game and you watch the final play where they pitched off to the running back, you probably made a gesture like this yourself, if you're a UT fan, of course. On the right, what is this young woman feeling? Well, this is Emma Raducanu, the tennis player, several years back when she came in second at Wimbledon very unexpectedly. So in fact, this gesture sort of says to everybody, I don't believe it. I can't believe what just happened. But it can be used for both elation and despair. Now, what are these people feeling? Upper right, well, people on the roller coaster look pretty happy, even though they've got their mouths open and their teeth showing and their brows furrowed. And on the right, what are these kids feeling? Well, you'd say they're pretty terrified. But in fact, they may get to the bottom and say, Mom, let's do it again. So again, the brain processes all of this in ways that we need to understand better. Now, once again, on the bottom left, this is one of the Williams sisters, and if you just saw the picture of her face, you would say, well, something terrible has happened. She's crying. Well, yes, she is crying. She's crying in triumph, but here it's a little less clear. Unlike the Indian weightlifter, you can't, unless you know tennis and know that she won, you can't quite extract it from the context, right? And then finally, more obviously, here are two people at the funeral of Princess Diana, a person that they had never met and only knew from seeing her on television and reading about her, but nonetheless are personally devastated. And what are they doing? They are, in many of these situations, they're crying, or they're crying. And people cry in despair, but they cry in moments of triumph, they cry in moments of grief, which is very interesting. If aliens came down from outer space to observe us, they would no doubt go back and say this is a very unusual species. When they are aroused, in certain situations, they squirt water out of their eyes. And how and why do we do that? Well, the neurobiology of crying is in fact quite complex. In the middle, in the pink there, you see the lacrimal nucleus that has specific projections to the lacrimal gland. You'll see the parasympathetic and sympathetic inputs, which tend to be responsible for just making sure your eye remains hydrated. But that lacrimal gland gets very sophisticated input from all of these yellow areas, and in particular from the anterior cingulate cortex and the amygdala. So it's aware of it's been being triggered by emotional stimuli, and it's also being provided information by the medial prefrontal cortex up there on right. That is part of the default mode network that we talked about earlier. So more about that in just a moment. All right. So more on crying. What is it for? Well, this is a very interesting study done recently. They asked female volunteers to come into the lab and cry. And these people made themselves cry by thinking about sad things. And they collected the tears. And then they brought males into the lab, into the scanner, to do a computer game where they were playing a mock opponent. And they could be aggressive during the video game. And these individuals did the scan under two conditions. Either they sniffed a placebo or they sniffed some of these female tears. Now, in the saline, the tears have no smell. They removed kind of the salty smell that may be in tears at times. And the particular chemical that stimulates the olfactory bulb does not produce any conscious sense of smelling when it's stimulated. So what happens? When these males sniff the tears, they are less aggressive and show reduced amygdala insula activation. So there you see right here, the amygdala insula area, it is particularly reduced in activation, all right? And the more difference there is between the more your aggression is, if we relate the difference in aggression when you're on saline versus tears to the PFC and the amygdala, that those correlate very strongly. So the more the tears affect your amygdala and lower its activity, the less likely you will become aggressive. Now that's rather interesting. How often do men get close enough to women that they could, quote, smell their tears? Well, obviously this would be a factor in intimate relationships. And this suggests a mechanism by which aggression is reduced in people who are in intimate relationship, at least those that involve a degree of kissing and other forms of intense, intimate relationships. Now, here you see people with different types of angry faces. And I don't think there's any doubt here that these people are angry. You're not going to mistake any of this furrowed brow or showing of teeth for any type of elation or happiness or grief. And humans seem to have two types of way of showing an angry face. One is the woman in the upper left and the man in the lower right. That is eyeballs either fairly open, brow still furrowed, but teeth being displayed. Now in our primate cousins, the gorillas, the chimpanzees, their teeth mean business. So if they show their teeth, that the prey or the person attacking them is in a lot of danger. Our human teeth, well, we can bite and do a lot of damage with it. We're not anywhere near our primate friends, so we need tools, we need weapons. But the other way we show anger is we purse the lips, and then the brow becomes more prominent. Now, if you imagine that you only saw this woman's eyes and nothing else, just looking at her eyes, you would be able to say, oh, that person is angry. And the humans show the whites of their eyes, and this is a way that humans can read emotion in a way that our primate cousins do not. And there's only one other species that can read emotion in eyes. One probably lives in your house, and that is the dog. Cats do not, contrary to what cat lovers believe. Now, we can measure this in imaging studies using the Harari task. And what they do here is people look at, in one set of stimuli, they look at faces. And what the task here is to push either the right or left button, matching the top face to the bottom face. So obviously here you're going to push the left button. And in contrast, other trials, you simply match the dots. So once again, you would press the left button because the horizontal oval shapes match. And generally, if you use angry faces or upset faces in the Harari task, this will strongly activate the amygdala relative to the shapes. Now, the other way we can do this is have morphing faces. So look at the bottom, you see at 100%, people are either happy, sad, fearful, or angry. And then as you move up, we move more toward the neutral face. Some people are better at identifying the face earlier in the process. So some people at 71% will say, oh yeah, that person's happy. Whereas other people need to wait until the full face is there. Okay, so hold on to these thoughts. So you've got your face making expressions, reflecting your internal state. You've got your periphery, your sympathetic and parasympathetic system that are governing arousal, but obviously there's going to be a lot more to it. So let's start with the insula. Here's the structure of the insula sitting right on top of the amygdala and hippocampus, just under the temporal lobe. Here's another view of it, and if you look over here, we see that red is sensory motor. So you're getting stuff from inside the body primarily. Yellow is chemosensory, so that's kind of your smell. Blue is social emotional, right there on the anterior part, and green cognitive. So the anterior part of the insula is kind of more for dealing with social cues, and the posterior part of the insula is picking up all this stuff from inside your body, as well as what you smell and taste. So here's your anterior insula connections, and they're kind of looped into our good friend, the Pepez circuit. And over in the posterior area, we're getting somatosensory, auditory, visual, and we're also going to get, as I mentioned earlier, we're going to get some input, from the body itself. And here's a little more sophisticated look. So here's our visual, our organ receptors coming in, taste receptors, thermal receptors, auditory, vestibular, kind of where your body in space is. And our integration here with the emotional social with output to the Anterior cingulate cortex, salience network, remember that. Amygdala and ventral striatum, again, salience network. And then to the hypothalamus, and that's where you get sympathetic activation as well as periaqueductal gray. Now, this may, you remember, hey, I remember you talking about the amygdala. This is kind of similar. You were absolutely right. The amygdala and the insula are close to each other, touching each other practically. They are a team. The amygdala knows about the internal state of the body and what's going on externally, and so does the insula. But the ratio is a little different. The amygdala is a little more externally oriented. There's that angry face. There's that food I like. Whereas the insula is a little bit more internally. What's the state of my stomach? What's the state of my bowels? Literally. How about my sex organs? And together they're matching our internal state to what's going on out there. All right. So insular function. I'm not going to read these for you. I'm just going to summarize them. Notice that, as I said, that we represent somatic sensation in the posterior insula. Whenever you do an imaging study and people are aware of the state of their internal organs, the insula activates. Whenever you are feeling like throwing up, that feeling of, oh, I got to get to the toilet, I got to get to the sink, I'm going to puke, well, that's your insula doing that for you. All right. Anterior lesions of the insula are associated with alexithymia. People are unable to use words to express emotions. Of course, it begins to deteriorate in Alzheimer's disease. People lose their sense of sentience, that they are a feeling individual. We get the insula activated to all kinds of sexy, weird, and aggressive stuff. So I start showing you, you go to see some slasher movie, you're going to get some good insular activation. For some people, that's horrible. They can't imagine doing it. For other people, they can't wait. They say, give me some more. And then the last, the anterior insula and anterior cingulate are core regions that form a large part of a large-scale cortical control network referred to as the salience network. And we begin to match what's out there to what's going on inside and use that to determine, do we want our default mode on or do we want our executive network on? And those two systems, as I said many times, are anti-correlated, and here's where the magic begins, in the insula. All right, here's a little bit more for you to read at your leisure. All right, okay, how is the emotion processed? Well, emotion is related in many cases to other people. As babies, as children, we learn by watching the reaction of the people around us. For instance, your 9-month-old baby bumps their head. You're sitting there, you will notice that there will be a moment where they don't quite know what to do. They've got that stunned look on their face. And then you go, oh, whoa, whoa, honey, did you hurt yourself? And all of a sudden, your right uncle starts to go, wah! They have looked at you and read your emotion. Oh, I cry. Oh, that's this feeling. I'm hurting. I'm supposed to cry. And then what you do, of course, you pick them up there, and oh, mommy's nice, I'm not hurting anymore, mommy's so wonderful. So we process motion in relationship to other people. And this is a skill that our primate cousins have. And our primate cousins, gorillas, orangutans, chimpanzees, they all have theory of mind, the ability to look at other people and understand how they feel. And here's a little video for you that describes this.
Cheryl, our vet, called me and she said, can you bring your baby in and feed him in front of Zoe because she had a baby. I just had my breastfeeding bra on and I was able to show her everything with zero modesty. I wanted her to be able to see the whole process because orangutans don't wear shirts. I wanted her to be able to see my breasts and see Caleb and be able to see him rooting and looking for it, and the latch with my bra down. I was very exaggerated when I put him on so that she could see that, like, the baby goes here, and the whole time I was talking to her and pointing at her, pointing at the baby, pointing at her breast, and when Caleb was latched, I was like showing it to her and making sure that she saw the important part. The whole time she just kept watching me, like, curious. She didn't immediately breastfeed her baby, but she was definitely watching the whole time.
So the orangutan doesn't know how to breastfeed her baby, because that's something primates need to be able to watch and learn. It's not something that they do instinctively. But she's able to sit there and watch a human breastfeeding and say, oh, she can do that, I can do that, and it's a nice thing. So this is key to understanding how emotions are processed, as you shall see. Now, this study is described in the book, and Lindquist set out to try to address a mystery in imaging study. So it was widely assumed when imaging was invented that we would find different regions of the brain responsible for different emotions. So depression would be in one place, feeling happy in another place, embarrassed in yet another. And the most obvious hypothesis was that, well, the amygdala is for anger and all the bad emotions, and the good stuff somewhere else. All right? So Lindquist put all these studies together, and what he found is that basically all emotions, positive or negative, activate the same general range of areas, primarily in this salience network. Now, when I say salience network and you don't know what I mean, go back to one of the earlier lectures and look in the book, to kind of clarify that. But here it's principally, amygdala, insula, anterior cortex, and some other areas that you can't see quite as well on the cross section. But you can see at the bottom, all emotions versus neutral, negative emotions versus neutral, positive versus neutral. By and large, all emotions are mapped into the same area of the brains. Well, then how do we tell the difference in our emotions? Well, one way for positive emotions is to see this little area of the medial prefrontal cortex. It appears to be preferentially activated when we're kind of experiencing a positive emotion. And this is part, of course, of the default mode network. And this mentalizing network, think about other people. Whereas negative emotions tend to particularly strongly activate the amygdala and insula. And here they're showing it in the left, which is interesting. The right surely is involved in some way, but nonetheless, this at least consistent with these old models of the amygdala is particularly important for negative emotion, but the amygdala will activate, as we've seen earlier, in positive emotions. For instance, we saw a study earlier that showed the amygdala activating strongly during parenting behaviors. Now, this becomes very important when we talk about the experience of depression. So, and how it differs from normal sadness. In this study here, the red represents insula activation when healthy people are in physical pain, and you can see that there. The yellow areas represent when the healthy individuals are remembering something emotionally very painful. And you notice that the yellow, for the most part, is separated from the red. But when we look at the green, particularly on the left, you'll notice that there's an overlap. And the authors suggested, and I think it's a good conclusion, that people with major depressive disorder are using the parts of the insula for physical pain to represent emotional pain. Now, interesting, we use physical pain words to describe depression. It breaks my heart. It pains me to tell you with this. I had a pain in my heart. That's quite intriguing. All right. When we look at emotions overall, what we're seeing is most of these active emotions, happy, fear, disgust, and sad, see how they're very similar in the way they're activating these networks. A little bit more of a spread to the right side with happy, and you see how these represent the cortical networks. Well, look what's happening in sad here. In sad, we are deactivating the cortex, particularly the more executive function sections. Well, what causes executive function areas to disengage? Well, when the default mode network begins to come online. So Arias and colleagues talked about how these different networks are involved in sadness. So the salience network, it's going to recruit those networks that give you that physical bad feeling of sadness. Your stomach sinking, you're bursting into tears. And it's going to then say, well, when our bodies feel bad, we're going to have a bias for internally directed neurocognitive processes. So, let's switch on default mode. What's going on? So here, we then look around. Something sad has happened, and we link those two things together. And then when that point, we get this diminished recruitment of the frontoparietal systems here. Now, there's normal sadness. We're sad for a certain period of time, but then we rebound. Well, what is the evolutionary significance of sadness? Well, but first, before I get into that, let's recapitulate. So, a sad event happens, and in humans, that's usually a loss in a relationship, death, breaking off the relationship, or the lack of reward, task failure. You've sent in your novel for the 25th time and it's been rejected. So this creates this disconnect between that and the internal state. Next step, insula produces a negative internal sensation. The salience network says we need to disconnect from active cognitive function, and the default mode activates with its internal focus. And you do a withdrawal from the world as long as it's adaptive. You need time to process the loss of the relationship, and maybe while you withdraw, you're going to say to yourself, well, maybe I'm not going to be the great American novelist. Maybe this is the time to go ahead and apply to go to medical school. So again, why depression? What is its evolutionary role? Well, we've got lots of good animal models of depression, and a lot of this is around maintaining social bonds. So losing a social bond is so painful. We don't want to feel the terrible loss that we do anything. We are highly motivated to maintain that bond. Whether that's caring for a child, caring for a significant other, caring for a pet, and that's very advantageous to the group. Similarly, when we have been defeated in competition, and animals, let's say you have two male rams competing for the female, and they ram their heads into each other, and one finally gives up and he bows his head, that's a kind of animal model of depression, but that's good for that animal. He doesn't get killed in the competition, and that ultimately is better for the herd overall. And we do see despair in animals, particularly when they're in deficient zoo or cage environments. So depression encourages the maintenance of social bonds because we don't want to experience. That's called negative reinforcement. Now, when it comes to mood dysregulation, we don't have good animal models. We don't have a good animal model of mania, so humans may be unique, and we don't have a good animal model of suicide. So we're going to have to look elsewhere for our studies, and we'll do that in subsequent lectures. All right, let's shift gears here. Let's get excitement and happiness. So people like to jump out of airplanes. They get a kick out of that. Not everybody, of course. And it may surprise you that in the that here in San Antonio at Brooks Field, we were the site of the first military parachute drop. These two men jumped out of a plane with a parachute and carried a machine gun with them, which is, I think, no easy feat. And they landed and they successfully set up their machine gun. And their objective was to prove to the generals that this would work, that you could get behind enemy lines and wreak havoc. As the story goes, the general at Fort Sam was not impressed, and at the end of it he said, "Thank God that's over and nobody got hurt." So one can imagine that a general who probably went to West Point in the 1890s and learned to fight on horseback and with a sword probably didn't appreciate modern warfare. Of course, 14 years later, that would be quite different. So we actually can learn a fair amount from skydivers. So on the far left, we see cortisol being measured in skydivers. The baseline day is just a day they're obviously not jumping. And then on the day they jump, you can see that as they get into the airplane and head up into the sky, cortisol spikes, and it tends to it little bit lags. You can see the jump and then the landing. It's spiking right about as they hit the ground, and then once they're presumably safely on the ground, it continues its back toward baseline. This is a normal cortisol stress response. You want to, when you're under stress, suddenly spike your cortisol, and then you want it to go back to normal, as we discussed in the neuroimmune lecture. Now, they then had these people in the scanner, and what they're showing in B is that the more you spike your cortisol, the more strongly you activate your amygdala. And that's shown even more on the right in panel C, where the more your cortisol changes, the more your amygdala increases. You see the positive correlation there. Now finally in panel D, what they're showing is also when the cortisol increases, the more likely your inferior frontal gyrus increases this activity. And that's part of the ventral bottom-up system that's involved in response inhibition, impulse control. Because generally, if you're going to be a good skydiver, you know, impulsivity is not the trait that you want. And again, the amygdala is activated, and most of these people are getting a big kick out of jumping out of this airplane. Now, another study has looked at sensation seekers who, interestingly, have low cortisol and low activity activation. So the people who were jumpers in this study did not activate their amygdala or pump out their cortisol. They put them in a scanner and said, when do you see the face is angry? Well, if you look there at 50%, you notice that the line intersects lower on the white axis, so they're more quickly to say, yes, it is aggressive. Whereas oh, excuse me, I'm mixing up the red and the blue. I always do that with this graph. This is a tough one. My apologies. All right, sensation seekers are a red line. I'm sorry, I thought that wasn't looking right. So you go up and you hit them at red there. It's the reverse. The face has to get 60% angry before they react, whereas and they are, if you now go across over to the y-axis, they're tending to respond, whereas the low sensation seekers at 50%, they're not being as aggressive. The bottom line, though, is really, let's go over to the left. In fact, let's forget this slide altogether. I got to find a better way to describe this. But the bottom line is the sensation seekers who have low cortisol, lower activity level will need a higher threshold to perceive the face as threatening. So they're not going to react as quickly. I believe that's what it's all about. My apologies on this one. Forget about it. All right. So let's look at some neuroendocrine aspects. Here are the testosterone the receptors in the brain. And you can see that they are fairly wide distributed. They're in the thalamus, that's C. They're in the amygdala, that's F. They are also in the pons, and they are in the temporal lobes. So they must have a wide range of influence, and they're in the putamen as well. That's D, as well as in the cerebellum, H, which is kind of hard to see. Oh, there it is. It's kind of hard to see the H. So testosterone all over the brain. We reviewed this these graphs in the book. They're in the earlier chapter. In other words, when people become aggressive, their orbital frontal cortex activity decreases. If you give external testosterone, you get people are more aggressive, and they get further decreases in their OFC activity. Now this one's, again, another tough experiment here, but it makes the point. High endogenous testosterone levels are associated with diminished neural emotional control. So they take these police recruits, and they measure their trait aggression with a psychological scale. So some are really naturally very aggressive and some are not. They measure their salivary testosterone. What they find is that the people who are very aggressive have more PFC activity than amygdala activity, the reverse of the low aggressive people. And their argument is these are people that are in the scanner and they're told they're doing this task where they have to inhibit their aggression. And so they've got to try really hard to do it. They're recruiting more of the PFC and trying to turn off the amygdala. Now, what they then bring in the testosterone, and here's the bottom line. People with the highest aggression had higher testosterone. They had higher aggression and higher testosterone, and they really need to juice up their amygdala PFC connectivity in order to do the emotional control task. Now, that's not a bad thing. So you could say, well, to be naturally aggressive, that might be a good trait for a policeman. But at the same time, you want that policeman to be able to control it. And to control it, you need you need the PFC connectivity to the amygdala. I got it. Now, testosterone has a wide range of effects on human behavior. It's been mainly studied in men, but it probably has some of these functions in women as well. It's particularly around aggression, but a lot depends on the social situation of the aggression, as we shall see in the next slide. So here you see that when men are engaged in intrasexual competition, that is, men competing each other either in games or trying to get the attention of the girls, there's increased testosterone, but also during camaraderie. When they're being friendly with each other, there's an increase in testosterone. Anyone who's been in the sports bar or the living room where a bunch of buddies are together watching the Super Bowl or the big game can see that right away. The increased arousal, the increase, oh, I can't believe he screwed up that play. You know, there's lots of aggressive type action probably being mediated by the testosterone. In contrast, when men interact with their offspring, they have a decrease in testosterone. The curious factor about that is that much of fathers and men's interaction with children is often around mock aggression, playing chase, wrestling, playing monster. So it's probably very adaptive that testosterone decreases in those situations. Now, what about estrogen? We have 3 types of estrogen receptors. I won't go into detail about those, but what is an interesting point is that there are estrogen receptors in the male brain, and we mentioned in an earlier lecture that fetal testosterone masculinizes the brain, but part of this is actually mediated by estrogen. So the testosterone in the brain is converted to estrogen, and some of that works on these estrogen receptors in the brain. Who knew? And the other fascinating thing is that in the cortex, estrogen receptors appear to be equally distributed throughout these areas. And you see there's a somewhat slightly different distribution. The beta receptors are found mainly in the hippocampus. I won't get into the details why. But it's obvious that the estrogen is important in prefrontal cortex, sensory motor cortex, in the cerebellum. Well, the cerebellum's involved in social behavior, as I mentioned earlier. We've not had the time to delve into that in detail, cerebellar function and social behavior, but not surprisingly, estrogen is involved there. And the only part of the brain where estrogen receptor distribution is sexually dimorphic is in the hypothalamus, again, as we discussed in the earlier lecture. All right. This is pretty confusing. You say, look at that, and really they don't go one way or the other. Sometimes estrogen makes women aggressive, sometimes it doesn't. The effects of estrogen are poorly understood. Estrogen does have major effects on attention and cognition in middle-aged women, particularly those who are post-menopausal. And given we've had a generational shift, my mother's generation all took hormones to prevent osteoporosis and post-menopausal symptoms, and then that was discontinued because of the fear of hormone-induced breast cancer, hormones as a risk factor. So now we have a lot of women entering menopause who do not have estrogen, and the question is, does that have effects on focus? And is there a kind of late onset female ADHD in quotes? That's of considerable controversy, but there is some literature in that area. All right, let's finally end by talking about impulsive aggression. Here's poor Phineas Gage, who had a rod rammed through his orbital frontal cortex. He was cognitively intact, but his personality changed. He became very impulsive and erratic, unable to judge the consequences of his behavior. So this small study, which unfortunately has not been repeated, was done by Kokoro way back now 20 years ago, just comparing 10 men with impulsive aggression to 10 control men. And what they found is that when the IED men were in the scanner, they much more strongly activated the amygdala to angry faces, and that degree of activation in panel B, the bold response, how strongly the amygdala activates, correlated with lifetime aggression. So that's quite intriguing. And they also found that the IED people underactivated the orbital frontal cortex, so they presumably had less top-down control and might assess aggressive behavior as being something worth engaging in. Now, this does not mean that these IED men were hardwired from birth to be this way. Perhaps the brain got programmed this way as a result of experience. The autonomic nervous system is very much involved to some degree in criminal behavior. There are very modest but consistent effects. Lower sympathetic nervous system activity as measured by heart rate or skin conductance is modestly associated with increased risk of criminal behavior in adulthood, and increased sympathetic nervous functioning is protective. So boys in a high-risk environment who have increased ANS functioning may have less risk of criminal behavior later on. All right. So finally, let's look at psychopaths. Psychopaths generally have a lack of remorse for what they do. And Yang and his colleagues looked at both successful and unsuccessful psychopaths. And they defined successful as that they avoided arrest. And they did structural imaging with these guys. I think there were some women in there. If you look at the top row, you will notice that the unsuccessful psychopaths have decreased volume in the medial prefrontal cortex, part of the default mode network, whereas the psychopaths, successful psychopaths, are quite intact in that area. Well, you can imagine if you're a bad criminal, an unsuccessful psychopath, you don't think very much about how other people feel. And you're going to make mistakes, you know. I don't think, in contrast, the successful psychopaths, particularly if they're con men, are probably very good at identifying their mark and knowing how to manipulate people. And their deficit appears to be in the far anterior temporal lobe, an area where the most abstract thinking goes on. So maybe the higher moral values that we all have just aren't as programmed as well in the successful psychopaths. Now, interestingly, both groups of psychopaths had decreased volume of the amygdala. So how do you think about this? Well, the unsuccessful psychopath isn't very good at thinking about empathizing with other people, taking their point of view. But even if he could, the amygdala, the salience network, the insulin network is not activating that bad feeling you would have about hurting somebody. And the successful psychopath says, yeah, I know exactly how that guy feels and I don't give a shit. They're not feeling anything internally that would somehow tell them, I really feel bad what I did to that person. And so here we can see when we do a moral reasoning task in the scanner, we activate the amygdala and we activate the default mode network. There's medial prefrontal cortex and there's posterior cingulate. Those areas are deficient in the antisocial people. And if we overlap them, we see in particular the default mode network and the amygdala that they're just not functioning there in these antisocial people. Again, may not necessarily be they were hardwired, but some aspect of their upbringing may have contributed to that, and that awaits further research. Thank you very much.